All right, it is 3 o'clock Eastern Standard Time, and it is time for another session of Dr. Yass Live on YouTube. And today we will be discussing symptoms from a variety of positions and points. I think most people who have any understanding of the Yass method recognize that the general premise by which the cause of symptoms is identified is through the interpretation of the body's presentation of symptoms. So whereas typically a diagnosis is derived by simply identifying a structural variation on an MRI or X-ray with no attempt to understand the symptoms, what brings them on, where's the location, is there any connection between the symptom that's being experienced versus what you would expect the symptoms to be if a structural variation was creating a symptom. All of this is put aside, and it's quite simple that they go ahead, get the MRI, get a result, and that result becomes the diagnosis for all future treatments. If anyone had seen the memo or what I had written regarding what I was going to discuss today, I pointed out that yesterday I had a very difficult circumstance arise because I met an individual who had an altered sensation in his legs. He described his legs as feeling like there was this cling wrap squeezing them together. That was his symptom. This was an older gentleman who had to take care of his wife, had to walk her around. She was in a wheelchair, and he was walking around, still capable of functioning, driving, and all this other type of stuff. But he had this altered sensation in his legs. So he somehow sought medical care from a surgeon who did an MRI and said that they had found a bone spur at the C5, C6 level, that is in the cervical level. And that supposedly the bone spur was causing this individual's symptoms in his legs. So the guy doesn't know anything about how to determine the cause of his symptoms. There was no attempt by the surgeon to present how they would suggest that this bone spur in the cervical spine region could possibly be creating symptoms in the legs. And so the guy agreed to get the surgery. Immediately after the surgery, the guy now has no use of his legs. He is actually not necessarily paralyzed, but it is called paresis, extreme weakness. The man cannot actively move either leg at all after the surgery. He contacted the surgeon. I had to ask, have you spoke to the surgeon since the surgery? And the surgeon simply kind of just said, well, there's some swelling that occurs, and eventually once the swelling resolves, hopefully you'll be able to move your legs again. And this guy is now talking about he wants a shotgun. That's what he's telling people. He wants a shotgun to kill himself because he cannot take care of his wife any longer. He's basically in a hospital bed with no ability to move his legs. And I met him yesterday, and I was, as always, emotionally distraught. It affects me so because this is a gentleman who simply believed that what this guy was telling him was the truth, that he understood that the cause of his pain was what it was stated based on an MRI finding, and that the symptoms would be resolved through the use of the surgery. And now he's sitting here with no ability to move his legs. And he's sitting in a hospital bed, laying in a hospital bed with no ability. His wife's at home. I don't even know who's taking care of his wife now. And I tell people I've been doing this for 27 years, fighting this fight against the MRI as the baseless mechanism for diagnosing the cause of pain. And I have been promoting for 27 years that the only way to understand the cause of pain is to interpret the actual presentation of symptoms, which are actually being elicited by that tissue in distress. It's not confusing to understand this premise that the symptoms being experienced are being elicited by the tissue in distress, because the tissue in distress is trying to make you aware of the distress of that tissue. And it's doing so by trying to knock you in the head and say, listen, you feel that? You see that? Whatever it is that it's doing, that's me telling you I need help. Please try to get the right type of intervention so that the distress of me can go away, and then I don't have to do this to you anymore. You won't have symptoms. Right? That's what this is all about. So if I had met this guy and I had had a chance to try to interpret his symptoms, I probably would have come up with a solution as to what was causing his symptoms. As we know, in 97%, 98% of cases, it's a muscular cause, even when it seems to be neurological, because in those particular cases, either it's a muscle impinging on a nerve, it is not a structural variation of the nerve, or it's a symptom being referred by the muscle itself. Most people have not come to the realization that muscles can refer symptoms just as nerves can. So the person who has that numbness in their hand when they wake up after laying on their side while they're sleeping, that's actually just an overstretching of the rotator cuff, which leads the rotator cuff to strain and refer the symptom down to the hand. That's not a nerve in the rotator cuff. That is the muscle itself straining. So in this particular guy's case, I'm sure I could have come to some solution. But here now, I meet this guy with virtually no ability to move his legs at all. And I'm going to have to really try to figure out what the hell happened here and whether there's even a chance that I can rectify what was done from this surgery. I just don't know until I spend more time with the guy. But it's these type of circumstances just reinforce to me the importance of what I'm doing and why I need to continue to reach out to people and make them recognize that the only true way you will ever know what tissue is creating that symptom is to interpret the very symptoms you're experiencing. I just got this. This is the kind of stuff that, again, is very humbling and makes me feel wonderful just on the sadness of that situation. Last night, I get an email from a woman in Australia who's having pain in her butt. She was told it was her SI joint. She's been treated forever. Nothing's gotten any better. She went and checked a couple of my videos on YouTube, just like the one that's going to be placed on there now. And she saw exactly what I said, that there's no possible way that the SI joint could be eliciting pain if there's no change in range of motion, because that's what joints do. They let range of motion occur. And so if she tested herself and saw she had no loss of range of motion, it couldn't be the SI joint, as she had been told for years and was unable to resolve her pain. She recognized that it was probably muscle, and now she's going to seek a Skype evaluation with me, which will allow me to confirm that it is muscular, confirm which muscles are involved, and help her resolve her pain once and for all. It's these type of things that continually make me say I need to stay on this quest. It's a crazy quest. It's a guy against a global behemoth, which is the medical system. But as time continues to pass, I'm just getting the sense people are coming more and more to the realization that it's failed. It's over. They're starting to realize it's not them. It's not the person that's the problem as to why they're still in pain. I continually talk about the idea your problem isn't that you haven't come to the right treatment. It's not that you've been getting the wrong treatments. It's that you've gotten the wrong diagnosis. Once you recognize that, you stop the nonsense. You walk away from this system, which is incapable of diagnosing, and you seek out somebody who may be willing and able to establish what tissue is in distress by interpreting your symptoms. That's how you get a right diagnosis. The Yass method, as far as I am aware, is the only method outside of the existing medical system that is a diagnostic model. It ignores diagnostic tests. I'm not aware of any other system. There's lots of treatment systems out there, but nobody is promoting that they have a diagnostic model different from the interpretation of diagnostic tests. So today we're going to talk about different types of symptoms you may be experiencing and see if we can kind of get you to have a better understanding of how to connect those symptoms to particular tissues. So the first one I wanted to talk about, which I think is one of the most common things people have, are pain or altered sensation at night. And what exactly does that mean? So if anybody's watching and you're having pain at night, it's confusing to you because that's when you're resting, that's when you're doing the least amount of activity, and you would think to yourself, I don't understand. If the pain is coming from something, why does it seem to be the worst when I'm doing the least? And the worst part about it is that these symptoms have a tendency to affect people's ability to sleep, which is one of the 4 pillars of health in my mind, right? Proper diet, proper exercise, proper stress reduction, and proper sleep are the 4 pillars of overall good health. So you're going to take down one of the legs of good health if you can't sleep. So here's the concept that I'd like to present to you. If the cause of your symptoms is muscle, what happens is during the course of the day when you're active, you are using your muscles. And the byproduct of muscular contraction is lactic acid buildup. Lactic acid within its name is acidic. The body does not want the pH of the blood to become too acidic because that's dangerous to you. So it's going to pump blood into the area where the muscles are working so that that lactic acid can be brought back to the liver and converted to pyruvic acid, which is an energy source. So in having this blood going into the area where the muscles are working, it keeps the muscles warm because blood is warm, and it keeps the muscles very distended, lengthened. Warm muscle could be stretched, right? So if it is a muscle that's created your symptom during your activity level, the highest probability is that the muscles aren't going to be able to elicit a lot of pain because they're warm. But what happens at night? At night, you stop doing activity. As a result, you're not developing lactic acid. As a result, the body doesn't have to force blood into the area where the muscles have strained to get rid of lactic acid development. So the muscles will not stay warm and lengthen. They're going to shorten back to their natural contractile length due to the straining. And if we recognize that, say, muscle fibers have pain receptors along their length, and this is supposed to be the optimal length of the muscle, but at night it contracts back to a shortened state, you can see how all the pain receptors that should be spread out this distance are spread out to this distance. That's why you get pain at night. Okay, so the reason you get pain at night is because most likely the tissue in distress is muscle. It has its greatest chance to shorten to its contractile strained position, which means you're concentrating pain receptors. What would be a good way that you could determine if what I'm saying is correct? Wake up and take a hot shower, right? If you take a hot shower, you're having the pain at night, you get up, you take a hot shower, and the pain begins to disseminate, go away. What does that tell you? It clearly must be muscular. If you had a herniated disc or stenosis or arthritis or a meniscal tear, and you took a hot shower, it's not going to unstenosis the stenosis or unherniate the disc or take away the arthritis. So if you see a reduction in your symptom with a application of heat, you have just proven that the cause is muscular. That's a very, very, very important thing for someone to know. You're trying to seek the appropriate care, and certainly by identifying the tissue in distress, that would certainly help to know whether it's muscle or structural. If it's structural, you're probably going to need a surgery, right? Diana wrote, hi, Dr. Yass, can you theorize on pins and needles pain down the back and front of the legs? So pins and needles are oftentimes, it can be neurological, it can be circulatory. It's very hard to say exactly what it is, but typically it is associated with strained muscle. So a sciatic, people often talk about sciatica as being pain, but pain, the sciatic nerve comprises 3 primary forms of nerve cells. It's got motor nerve cells, which are the cells that innervate muscles. It's got pain nerve cells, but it also has altered sensation, heat, pins and needles, all this type of thing. So You can actually, and a classic example of this, not to get a little too weird, but if you sat on a toilet for a sustained period of time, eventually you'd start to feel your feet start to go numb, right? I think most people, maybe you're concentrating on a book, or you fell asleep, or you're thinking about something, you don't realize how long you're sitting on the toilet, right? That toilet seat is pushing into the inside portion of the rim, is pushing into the back of the thigh, which is compressing the sciatic nerve. So you could get altered sensation in the feet by doing that, right? Does that make sense to people? Right? Well, if a muscle impinges on the sciatic nerve, the same thing can arise. You could also get pins and needles, as I described, let's say in the hand, maybe not necessarily the leg, but in the hand, when you're laying on your arm, on your shoulder, and the shoulder bone gets pulled forward because the rotator cuff is not strong, it's weaker, and it allows that to happen, which overstretches the rotator cuff. The rotator cuff muscles can refer symptoms, not just pain, but it can refer altered sensation like pins and needles. That's the person who wakes up with the pins and needles in the hand. You could get it more generally in the hand if a muscle in the front of the neck, called the anterior scalenes muscle, impinges on the brachial plexus. The brachial plexus are all the nerves that come, the nerve roots that come out of the cervical spine, joined together to form this bundle of nerves called the brachial plexus, which runs under the collarbone and under the arm and goes down and innervates all the muscles and the area of skin of the arm. Well, again, that forward shoulder posture can cause a shortening of the anterior scalenes to impinge on the brachial plexus. It's just really important to understand that things like you're describing, Diana, this idea of pins and needles doesn't necessarily refer to a neuropathy. It is the greatest false diagnosis that exists, neuropathy. It's a meaningless diagnosis. And it's meaningless in the sense that there's no physical presentation that would show that there's some structural variation to a nerve. Neuropathy implies nerve, opathy, pathology, a pathology of a nerve, implying that there's some structural deformation of the nerve. What's the physical presentation of that? Nothing. But can you show a physical presentation of the muscle straining or shortening? Yes, clearly. Variations in posture, variations in strength, length, palpation, movement pattern. All of these type things are representations that show that there's been in a sense, pathology of muscle, but not so much pathology in terms of a tear, but in a straining of a muscle. So let's not jump to the conclusion that when we see pins and needles or feel pins and needles, that immediately means that there's some sort of neuropathy, because generally I have never seen evidence of a neuropathy. And yet everybody comes to me and they're diagnosed with that as if there's some great value to it, but the value of it is meaningless, other than it gives the doctor an opportunity to give you a diagnosis so you can get medication like Neurontin. And by the way, I was just having this discussion with somebody, right? Neurontin is used for altered sensation and for pain. Does anybody know what its actual, what it was, the patent was received for? Does anyone know what Neurontin really is? I don't think anyone would probably know this. It's an anti-seizure medication. Neurontin was patented as an anti-seizure medication, but it is used for pain and altered sensation because it got a secondary patent, a secondary usage permit, right? Not a patent. There never was any double-blind study done, no efficacy checks or anything like that. The manufacturer just somehow gets approval for it to be used for some other type of usage outside of what it was patented for. And that gets pretty scary. So for everybody who's being taken, or everybody who's taking it or knows somebody, I need you to understand, you're taking an anti-seizure medication for a symptom where all they got was a secondary usage, but never was patented for that usage. I've been working really hard to strengthen the glute medius, so I know I'm doing that right, but the pins and needles is really interesting. Can other muscles elicit this response? Well, there's no question you can. So even the gluteus medius can actually refer symptoms. You know where the gluteus medius is? We've talked about it here. Here's your gluteus medius. If you're pointing right up here, if we look right to the back here, that's your gluteus medius. You can see it detached from the side of the pelvis all the way down to here. That gluteus medius, remember I said muscles can refer symptoms. That can refer symptoms down the lateral aspect of the thigh. So you could get pins and needles down the lateral aspect of the thigh, and that actually can be coming right here from this strained gluteus medius. We've talked about the sciatic nerve being impinged by the piriformis muscle. That can refer altered sensation, including pins and needles, down the back of the thigh to the foot. People have had pins and needles at the underside of the foot only. Okay, there's an interesting one. What is causing pins and needles to the underside of the foot? Well, if we look at the foot and you see that there's an arch on the inside portion of the foot, you would recognize that only the outer portion of the foot is designed to touch the floor. The portion where the arch is not designed to touch the floor, right? But if you lose support of your arch and you go from an arch like this to a flattened portion like this, that inside portion of the foot under the arch is now going to be compressed on the floor. It wasn't designed to take that. So that compression, that sustained compression, will cause irritation of the tissues below it and can lead to pins and needles. So you could have pins and needles at the underside of your foot simply because that area of skin is being compressed where it was never designed to be compressed, because the arch was supposed to be suspended, like an arch is supposed to be, right? So there's lots of reasons to get pins and needles in different places. What's the answer, though? Understanding exactly where those symptoms lie, so that you can come up and establish what tissue might be creating the symptoms in that location. That's why this interpretation of your symptoms is so freaking critical. All right? So that's the night concept. Here's a very important one. I just did this with a lady. I just did a Skype with this lady. She's in London. And she had pain in the groin. And she was told that she was bone on bone and that the hip joint was referring the symptom to her groin, which is why she needed a hip replacement. So I'd like to just briefly discuss the idea, because this is something you guys could do on your own, is to differentiate whether a symptom is referred or whether it is point tender. Referred implies that the tissue in distress is not in the location where the symptom is being experienced. It's somewhere else, and irritation of that cause is creating a referred symptom to another location. So in this case, this woman is having symptoms in her groin, and she's being told that it's coming from the hip joint. The hip joint you would experience, if you wanted to feel it, is on the outside of the thigh. She's saying that her symptom is in her groin. So for me to create the symptom, if it was referred from the groin, I would basically have to push in right here. I would push in. She'd be laying on her side, and I would force the hip bone, the thigh bone, into the hip joint, and she would then experience the pain refer to her groin if it was coming from here. And I had to try to do it. She could not bring it on. Then I had to press in her groin exactly where the symptom was, and she was able to bring on the symptom. So that showed you that that's not a referred symptom. It's a point tender symptom, meaning that when you press where the symptom is, you bring it on. That tells you the tissue that you're pressing on is the tissue that's eliciting the symptom. In this particular case, it was her sartorius muscle. So by understanding the difference between a referred symptom and a point tender symptom, you have a very strong ability to interpret the physical presentation of symptoms to confirm or refute a diagnosis derived for an MRI. Another classic example, let's say someone's having pain right here. Very, very common to have pain right here, that upper trap region. You're told that that's coming from a herniated disc, a pinched nerve, or stenosis at the cervical spine. That would say that you would have to press somewhere here in the cervical spine, and you would then have to try to feel it shoot to the upper trap region. Well, you could spend all day trying to do that, and it's probably not going to happen. But if you then pressed on this spot and you said, oh boy, that does bring on the symptom, you again have shown that the pain is point tender and not referred. If you can show it's point tender, you have just disputed the idea of that herniated disc or stenosis or pinched nerve found on an MRI as being the cause of your symptoms. You've just confirmed irrefutably it is not that. That, in fact, it is the tissue you're pressing on here, which happens to be the levator scapula, a muscle that supports the head and is attached to the shoulder blade. So understanding how to differentiate a symptom from being a referred symptom versus point tender is critical in the assistance of identifying the tissue in distress. Okay, another common thing that people have told me about is that they have traveling symptoms. So let's say someone started having pain in the right hip region. And this is very common. This happens often for people, and they're manipulated into multiple surgeries because they're not understanding what's going on, why their symptoms are traveling. So you start with pain in the right hip region, and let's say someone coerced you into getting a hip replacement on the right side because you were told it was bone on bone. So after the surgery, you don't feel the symptom in the right hip region anymore. But 2-3 months later, you're starting to get pain at the left knee. So the pain traveled from the right hip region to the left knee region. And the person then gets an x-ray, finds some arthritis, and they're told, oh, now you're bone on bone at the left knee. And so you need a knee replacement on the left side. So the person gets the knee replacement at the left side, and now they don't have pain at the left knee anymore, and they're coerced into thinking that this was a success. But now they're getting pain at the right ankle. So now they get an x-ray. It says there's some arthritis at the ankle on the right side, and now they're coerced into being told that they need a right ankle replacement. So what's happening is they started off with pain at the right hip region, went to the left knee, and ultimately went down to the right ankle. What happened? What happened was they had a muscular cause at the right hip region. It was unidentified. They got a right hip replacement. Due to the severity of the pain, swelling, and decreased weight bearing that would come from that post-surgical symptoms, they ended up now excessively weight bearing on the left side. Well, the muscles that support the left leg weren't designed to take 2 legs worth of load. So that excess load left the left muscle surrounding the knee straining. So eventually they strained and elicited pain. The person was coerced into thinking it was a joint requirement to get a knee replacement. So they got the knee replacement. Now, the post-surgical symptoms of that knee replacement made it impossible to weight bear. On the left leg, they went back to the right side. The load was greater than what the right leg was supposed to take, so it strained, and now they ended up having pain at the right ankle, right? And now they get a right ankle replacement. You can see how this situation is just going to cause people to have pain on one side, then the other, pain on one side, then the other, pain on one side, then the other. You're not recognizing that the legitimate reason for pain in typical is that the force requirements are greater than the force output of your muscles. And all you do is in getting these types of surgeries, or oftentimes you will just change how you move or function. You're just shifting where you're weight bearing from one side to the other. And it's just causing other muscle groups to end up having pain. That's all that's happening. But the problem is that you're never getting to the point of recognizing where the force deficits are in comparison to the force requirements. So this just goes on forever and ever and ever. And you will ultimately possibly get multiple surgeries, or worse off, you'll just convince yourself, or someone will try to convince you, hey, you just have to stop doing those things that are leading to your symptoms, and your quality of life will collapse. Does everyone understand why their pain might travel now? Does this at least make a little more sense? I think people are very confused, and it gets very scary when you start having your symptoms traveling, because now you start wondering, is there something more systemic that's leading to my symptoms when it starts traveling all over your body, when in fact that all that's happening is you're just shifting your weight bearing. Hopefully that makes sense to people. And again, understanding these type of things are the types of things that will help you be able to finally get to the point of knowing what tissue is in distress and how do we resolve the distress of that tissue once we identify that tissue. This is it. It'll sound like a broken record, but ultimately that's what this is all about. Establish cause, resolve cause. Establish cause, resolve cause. Don't just get a diagnosis and keep getting treatments. And when all the treatments fail, think, oh, the problem is that I haven't just found that right treatment. That's crap. That's insanity. That's pure lunacy. If you're getting a bunch of treatments and you're still not getting resolution, you kind of have to start to look at the diagnosis you've gotten and assume possibly that the diagnosis is wrong, that the actual diagnosis is where the fault is, not in the types of treatments. Different. Let's see what right here. Different from symptom. Oh, so that was another important point that I wanted to make to people is that the cause of your symptoms in 99% of cases is going to be different from the location of your symptoms. And I kind of want to give you an example of how one cause can create symptoms at multiple locations. Watch this now. This is really interesting. So if you're having multiple symptoms, so let's say that you have symptoms at your back, let's say your knee, and let's say your ankle, let's say your foot. You might go to a back doctor, a knee doctor, and a podiatrist, assuming that these three different areas have different causes and therefore require different types of doctors. Now watch this. Let's say that your right gluteus medius, we'll go back to this guy strains. Now you see how it's attached from the pelvis to the hip joint? If it pulls from the pelvis down to the hip joint, you can see that its goal is to keep the pelvis level. But let's say it strains, and this is the right side. That left side is going to start to drop, okay? And what happens is the distance from the top of the pelvis to the floor will shrink, and it's going to make it so that there's less area for your foot to travel through when you're walking, and you could be susceptible to tripping. And the body's going to say, well, I can't let that happen to you. You're going to trip. So what it does is it's going to take this and try to raise it up. And the way it raises it up is there's a muscle here called the quadratus lumborum, a lower back muscle, that attaches from the bottom of the ribcage to the top of the pelvis. So it's going to try to contract, okay? So when it starts to contract, it's going to try to help assist in this muscle. Well, it wasn't designed to do that, so it's going to strain. And eventually, it's going to strain and it's going to elicit pain. So you could have pain right here in the right lower back because the left gluteus medius has strained, okay? So the lower back, right lower back is having pain because the left glute med strained. Now, let's take it from the other side here. You can see, imagine if it's trying to pull on the hip joint from the pelvis, you can see that it's going to try to pull it out this way. But let's say it's strained. This is going to start to jog in, and you're going to see your knee start to cave in. Well, instead of being able to weight bear through the entire surface area of your knee joint, you're going to only be weight bearing on the inside portion of the knee because your knee is caved in. So the force load is just at the inside of the knee. It's not at the entire surrounding surface of the knee. So the muscles on the inside of the knee are going to have to work very, very hard because there's a load there it wasn't designed to take. All the muscles surrounding the knee were designed to take that load, not just the muscles on the inside of the knee. And as a result of that, those muscles are going to strain, and you're going to end up with straining your hamstring or your sartorius muscle right at its attachment near the inside of the knee. So this sucker has now created pain at the right lower back and the left medial knee. Take it down further to the floor. Well, once you weight bear on the inside of the knee, you're going to weight bear on the inside of the foot exactly where the arch is. The arch has two muscles that support it, and with that excess load, those muscles aren't going to be able to take that excess load, so they're going to strain. You're going to get a flattening of your arch. in flattening of the arch, the distance between the balls of the feet and the heel increases. That means that the plantar fascia is now going to become overstretched. It's going to elicit pain at your heel at the underside of your foot. What is the cause of that plantar fascia straining? Because of elongation? Strained gluteus medius. One cause created pain at the right lower back, the left inside knee, and the underside of the foot. You would have gone to a back specialist, a knee specialist, and a podiatrist, and those three schmucks combined wouldn't have been able to figure out what the cause is, but they would have given you an epidural nerve block, a cortisone shot, and an orthotic. And you would have been one iota closer to resolving the cause of your pain because you never interpreted your symptoms. You never said to yourself, wow, all three of these things are happening at the same time. What is the connection? But the Yass method doesn't have any problem in doing that. The recognition of the pain on the opposite side would have given me an immediate hint that there's a glute med. It's only on one side. I would have muscle tested you, seen that it was much harder for you to single leg stand on the left leg. I would have seen that your knee was caving in every time you picked up your right foot, and I would have seen that your arch was collapsing every time you stepped on the left foot. I would have muscle tested you. I would have palpated the muscle. I would have seen that the glute med had a gigantic knot in it. I would have seen that the right QL had a knot in it. I would have felt that your plantar fascia had knots in it. All the evidence would have been there to tell you all three of those locations, one cause. That's what the Yass method does. That's what the interpretation of your symptoms represents. This is very, very scary stuff. This is very, very scary stuff. Hip replacements, knee replacements, and perverse back surgeries are being performed arbitrarily because people are getting MRIs showing diagnostic tests finding structural variations, herniated disc, stenosis, arthritis, meniscal tears, labral tears, all this nonsense. And simply because they're identified at the same time the symptom is existing is said to be the cause of the symptom, even though the presentation of those symptoms are symptoms that could never be created because they're not where they would be if the structural variation was creating a symptom itself. An example of that would be if you found that you had an L4-5 nerve root impingement, which is one of the more common ones people get, and they're told that's the cause of their back pain. You have to know that that nerve root, the L4-5 nerve root, innervates a certain area of skin, just as every dermatome. Every nerve root innervates a certain area of skin. The L4-5 nerve root innervates the inner shin. So unless you're telling me you have a symptom, altered sensation, pins and needles, numbness, something at your inner shin, you can't tell me that the L4-5 nerve root impingement is creating a symptom because it can only create a symptom at the inner shin. There is no connection between the L4-5 nerve root and pain at the lower back. It doesn't work that way. You don't need a medical degree. Google dermatomal chart. Dermatomal chart. Look at it, and it's going to show you on the body where every one of those nerve roots that come out of the spine innervate an area of skin. And you'll see they're kind of diagonal as they come out. And look at the end places where they are. That's where the area of skin is that would have to have a symptom for one of those dermatomes to be saying it's the cause. So L3, for instance, is the front of the thigh, right? So watch this. Here's an example of how we look at symptoms to see if it's referred or pointenda. You have altered sensation. Diana was talking about this. You have altered sensation, pins and needles at the front of your thigh. How could you determine what its causes? So let's say, for instance, two people get MRIs. Both have numbness in the leg. Both have an L3 herniated disc presented. How would we know if either of them have that herniated disc as the cause? Watch this. I would have to press on the L3 nerve root area in the back, and they would have to say, oh my God, I just felt that shoot to my thigh, my front thigh. Right? Now, if that happened to somebody, then you could then begin to suggest that the cause of that symptom is from the spine, and they might be considering a surgery. But what if I press on the front thigh and they say, whoa, the symptom increased dramatically? I pressed on the spot where the symptom is, which indicates it is point tender, which is to say the tissue I'm pressing on is the one creating the symptom. So you have a strained quad. And it's literally just referring symptoms in its area. All the back fusions in the world aren't going to fix that problem, not when it's point tender. Does everyone understand this? How understanding how to interpret your body's presentation of symptoms goes well beyond the ability of a MRI to identify it. I'm telling you now, you got two people. One might need the surgery, the other guaranteed doesn't. Right? Absolutely doesn't. If I press on the front thigh and there's altered sensation there and I make it worse, I have just proven that it is the tissue in the front thigh, the quadricep, creating the symptom. The only way I can say it is from that L3 nerve root is if I press in the area of the L3 nerve root in my back and it shoots the symptom to the front thigh. Referred symptom, point tender symptom. Danica, welcome to my world. Back, knee, and foot problems. Right. So when you see that you have symptoms in multiple areas, does it make more sense that there's some sort of connection to all of them? Or do you legitimately think that you just have multiple things breaking down in your body, especially when you see that these symptoms are worsened by activity? When you see that they're worsened by activity, you have to start to say to yourself, it's probably muscular, and muscles work synergistically. They work together to create activity, function. So if one breaks down, the highest probability is, or others are going to try to compensate. That should make sense to people. So if one breaks down, maybe one over here is trying to compensate and creates a symptom. One over here is trying to create a compensation and elicits a symptom. Doesn't that more make sense than you have some sort of structural component in the back, a structural component in the knee, and a structural component in the foot all breaking down at the same time? What are the odds of that? Does that make sense to anybody? I would hope it would be like, this is just too weird for that to happen. And then the other thing that I wanted to talk about was intermittent pain. This is apparently, Diana had mentioned this was something she wanted me to describe. And so intermittent pain is the fact that you're using an area for activity, you're straining muscle, so eventually you get the symptom to occur. And what happens when you get enough pain? You stop doing the activity. Well, if you stop doing the activity, you stop straining the muscle stops becoming irritated, and you no longer have pain. But if you go back and do the same activity the same exact way, you're going to bring this symptom back. So this idea of intermittent pain should hopefully make you have a red flag to the idea that your problem is a herniated disc stenosis, arthritis, or a meniscal tear. Because if someone's telling you that the pain at your shoulder is arthritis, that is the arthritic change they're saying is the cause of your pain. And you have pain sometimes, but you don't have pain others. Are you implying that during the time you're having your pain, you have arthritis, but during the time you don't have the pain, you don't have arthritis? Are you saying it's appearing and disappearing? Is that what someone's trying to explain to me? There's narrowing, which is what stenosis is in your lower back. I'm doing activity. It's stenosis. It's stenotic. It's narrowed. When I rest and I don't have pain, now it's not stenosis. I've somehow provided cushioning. Does that make any sense to anybody? You see how by interpreting your symptoms, really interpreting them, not just pain or not pain, but what they are. Are they intermittent? Are they at multiple places? Do they seem to travel? Are they referred, or are they point tender? All of these things are what make the Yass method the Yass method. It is a full understanding of symptoms. That's what you need if you're ever going to be able to understand the cause of your symptoms. So, and from the understanding of the cause of symptoms, understand what tissue is in distress, eliciting them. So I thought this was a really good opportunity to discuss symptoms as a generality versus specific to any particular diagnosis or area or joint. I thought this would be very helpful for people. So I think that's good. If anyone has anything they want to chime in on, or if they have a question or anything, please do so. In the meantime, I always want to thank everybody for coming to my videos. I just had another person from Australia. This is great stuff, man. This is really great stuff. Someone from Australia just contacted me, as I think I said. It's getting out there. The message is getting out there, and I believe I'm winning the war. It feels like it's person by person, but it's okay. I'm just happy every time someone gets a chance to recognize there's an alternative outside of diagnostic testing that is completely legitimate, is completely viable, is incredibly accurate, and that is the interpretation of the presentation of symptoms. So if you do like these videos, please give them a thumbs up. That is an important thing, apparently, for YouTube and Google. If you like my website, if you know of anybody who's having pain, and see if you can convince them to come to the website. If you like the channel, please subscribe to the channel. Just go on, Dr. Mitchell Yass, right? That's my channel here. I'll write it here. We'll try to get it down here for everybody, right? So on YouTube, Dr. Mitchell Yass. That's the website. That's my YouTube channel. If you're liking what I'm saying and it's making sense to you and it's helpful, please subscribe to the channel. The reason for that is that once you subscribe, you get notifications every time I put a new video on or every time I'm going live. And the live aspects are for people to be able to interact with me. I think it's really important. So please subscribe and like the videos. And if you know anybody, Diana's a big advocate of the Yass method. She's out there trying to get people. You can't force people to change from the existing system. All you can do is give them the opportunity by providing the information. And then if they're willing to, on their own time, they will seek it out. And that's what's happening. People are now really contacting me at a pretty nice level. And it's just, I was in pain, couldn't get better, went out, searched around, found your information. It makes so much sense. I'd like to get some sort of treatment from you. So again, the YouTube channel is where I'm getting most of the content out. Subscribe if you like the channel. Give it a thumbs up if you like the videos. If you want to get to me directly, my email address, I'll put it on there. It's Dr. Mitch at MitchellYass.com. That's my email address. If anyone wants to reach me, please do so. I'm here. We do Skype evaluations or Zoom evaluations and treatments. I've been doing this for years. I know the telemedicine thing's becoming a big thing, but I've been doing this for years because so many people from around the world have been interested in getting my treatment. So they just weren't in a position to reach me live. So that's the story with that. If no one else has anything else they want to contribute, let me just sign off here by saying this is Dr. Mitchell Yass wishing you a pain-free, fully functional life. Let's resolve chronic pain globally. Let's work together, and let's get people to realize they don't have to end up like that poor guy who's now paralyzed from a surgery that was never going to work and he didn't need. So, all right. So for now, let's resolve pain and let's have the lives we all so justly deserve. Bye-bye for now.